Hey, Mark.
I was wondering when you get to Mark, how you doing? Good. Okay. Yep.
Glenn went to get a cup of water, so little cup of water.
When you say Austin Pfeffer, right? And maybe then I'll be like, so what's up, Doc? Right?
Yeah,
didn't Bug say that all the time?
Yes. What's up, Doc?
Hey, what's up, Doc?
All right.
All right. So Glenn,
I'm not sure I'm the person I was at 7 a.m.
Okay.
That's okay.
Listen,
So-
we are not the people we were at 7 a.m. either.
So if there's something, Elizabeth, you feel I should really get at, I know you'll bring it up.
Yeah.
I was in the OR till late. And
Oh, gosh.
Stop with the excuses.
Oh, she has no sympathy. Jeez.
that's good. That's
Come on,
good.
back up.
The Barbara
So,
Walters of the CMT world.
Right. So,
We have kind of a long intro.
So
Sorry
we
about
have
that.
our intro. So just kind of sit and listen. But we have a good intro in terms of that leads up to your introduction, and we'll have some fun with it and just roll with it. If you do at any point you're like, yeah, I wish you guys didn't put that in there, that's cool too. We can edit all this stuff, but we like to have a little back and forth, and that leads into the introduction of yourself, our special guest. So thank you so much for joining.
Yeah.
Okay.
Okay.
All right. So Elizabeth and I are going to go, and then you'll get the cue when we're ready to introduce you. Okay. We'll say like, oh, welcome, Glenn. And you'll say hi. And then we'll say, if Elizabeth will say a few other things. So if you want to laugh, go ahead and laugh. Okay. All right. So we're recording. What was that?
He goes, ah.
Yeah.
I laughed. Okay.
If you can avoid that laugh, Elizabeth, that'd be good, because that isn't so annoying. But anyways, all right, here we go. 1, 2, 3, 4. Hello, everyone. This is Chris and Lizzo.
We are a brother-sister team.
On behalf of the Charcot-Marie Tooth Association, aka CMTA, we are coming at you.
Coming at you from coast to coast. I live in California and Chris lives in Vermont.
That's right. And this is another fantastic episode of our famous podcast name. What, Lizzo?
CMT, the number 4, me.
That's right. CMT for me, a comprehensive podcast covering all aspects of CMT, the voice of individuals living with CMT, their challenges, and more importantly, their inspirational stories. We also cover research updates, insights from experts, fundraising, interviews with the CMTA community, and overall, an opportunity to spread awareness through the eyes of those with CMT. So, Lizzo, first off, did you know that our podcast is ranked within the top 10% of all podcasts downloaded within the first week, according to Buzzsprout?
That's
pretty cool.
I couldn't believe it. I was so excited. I was sending emails to everyone.
Yeah, it's awesome. And the other item I want to mention and poke out there for everybody, Lizzo, we only have one review online.
I put I put it up there.
Oh, and you're the one that put it up there. Okay, great. So, folks, help us engage more listeners by posting your comments and reviews online. And by the way, positive comments only, please. So, as I transition, I'm really excited about our next guest, and I'm sure our listeners feel the same. So, kick it off, Lizzo. Have you ever had surgery in your life?
What? Seriously? You grew up with me in Vermont, in Burlington, Vermont, lived with me all my life, and you don't know if I've ever had surgery? Are you really my brother?
No, I guess this is a good time. You were adopted, and it's taken me 55 years to tell you this. I figured I'd do it over the podcast.
Yeah, that's great, Chris. Just awesome. Yeah. Okay.
Yeah.
You're the one that was adopted.
Okay, keep going.
Of course, I've had surgeries. I had 2-foot surgeries for neuromas. Then I had a sesamoid bone. I don't know if I pronounced that. A sesamoid bone taken out. It cracked.
A sesame seed?
No, a sesamoid bone or something like that.
Right.
And they took it out. A sesame seed. And as much as I love Vermont, I don't think if I had thought back then what they were doing that I would have had my surgeries in Vermont. I did. But I'd probably find the best doc around for my ailments.
That's a good point. And surgery can be very emotional and intimidating. Imagine going to the hospital, the uncertainty of the outcome, going through physical therapy, potential pain and discomfort, etc.
Yeah. And at the time, I just wanted the problem fixed so I could get on with my active lifestyle. I'm like, yeah, whatever, just fix it, take it out, whatever. And, so I have had surgeries. But you were the accident prone brother, if I remember. Why don't you tell us a little bit about your surgeries?
Well, I had a few in my life: broken femur, torn ACL, broken humerus bone, broken middle finger, broken nose, and probably more. And do you remember when I threw that snowball and I broke my arm?
Yeah, that was weird. That was just
From
really
throwing
weird.
a snowball.
Yeah.
And Mom always said that's because you would punch me in the arm all the time, that you really destroyed my humerus bone.
Well, I don't think it wasn't humorous at the time, and it's not
No.
humorous now. And I still feel really guilty about that. But
It's fine.
I don't think that was the cause. I think he had a cyst in the bone or something, and we didn't know. But anyway, whatever. It stopped me from wrestling with you.
That's right. But in all seriousness, there's decisions that go into surgery. Whether you should do it, which was the case with my ACL. I felt fine and I could live with it. However, I wasn't confident that I'd be able to ski or cycle at a higher level. So I made the decision: get it done, move forward, eliminate obstacles that it could. I'm going to repeat that, Mark. So edit: get it done, move forward, and eliminate obstacles that could impact my ability to enjoy these activities.
Yeah. And since we're going to bring it back to CMT, CMT foot surgery is really scary, in my opinion, as mom with a child with CMT, who's really a young adult with CMT. And it has a fairly long recovery time. I think a lot of people wait way too long until they're unable to walk. And then they show up and they have a really rigid foot and it doesn't flex very much. But, what do I know? Let me introduce our next guest.
All right, let's do it.
Okay, here he is, the man with a plan, Dr. Glenn Pfeffer. He is the most well-known CMT orthopedic foot surgeon in the world.
In the world?
In the world, globally.
Awesome.
He's the director of the foot and ankle program at Cedars-Sinai in Los Angeles. I consider him a friend, a reputable surgeon, and a man dedicated to all people with CMT and their families.
Welcome, Glenn. We're so psyched to have you.
Thank you very much. Good.
So, Glenn, before we get into the nitty gritty here, I looked up the meaning of your last name, Pfeffer. I was always wondering, what does that mean?
Huh. I don't know. Sorry, hold on, Glenn. I always think about, does that mean stew? Remember the Bugs Bunny show when the king asked Yosemite Sam to bring in the Hassenpfeffer?
Yeah, he goes, bring me some Hassenpfeffer.
So
Glenn, so does Pfeffer mean, I think it means like in German, hot, spicy, fiery. Glenn, does that describe you?
Well, no. But it does mean pepper in German, right?
All right, cool.
And there are more horizontal lines in it than any other word I've ever seen in my life. It's a lot of F's.
Yeah.
Yes.
But you're right. Hassenpfeffer, Salsenpfeffer.
I'm sure you've heard it all.
So Glenn, as we start on your introduction, as we usually do, tell us a little bit about yourself and, how you got engaged in surgery and science. And, what I recall when we did a pre-interview, you're an individual that is really, really passionate about helping with people with CMT.
Well, you're on the East Coast now. Elizabeth's on the West Coast.
Right.
I've certainly got a lot of each of those in me. I was born in New York City, down in the Lower East Side, a place called Stuyvesant Town. We spent a good amount of time skiing in Vermont, going through New Hampshire. And then we moved out to San Francisco, and everyone out here warned me. They said, look, after the first year, you're going to really miss the East Coast. And after the second year, you're going to be a little ambivalent. But by the time you go back the third year and you see, at least in New York City, the traffic and the weather, you're not going to want to go back. And that's really what happened. After the third year, I stayed. I was in San Francisco for about 18 years. And then I came down to Los Angeles to work at Cedars-Sinai, where I've been. In terms of, I'm an orthopedic surgeon, so I did all my training on the East Coast. And then I did a hand fellowship, which was great because with the hand, you're working with nerves and small bones. I ran the Army Hospital in San Francisco in the Presidio for a while. And I did a foot and ankle fellowship. So I was a small coterie of people who had done both hands and feet in the United States. And it's something I really like. You know, I'm a guy who enjoyed working with models when I was a young kid. And so it really suits me. In terms of the CMT, right? It's CMT if you doze off in medical school for maybe 3 or 4 minutes, you'll miss the entire coverage of CMT. At least when I went to medical school, you know, and in orthopedics,
you even stumble across CMT.
No. Now you do. Now you do much more for lots and lots of reasons. But you know, back in the late 70s, early 80s, when all of the senior generation of orthopedic surgeons were growing up, there wasn't really much discussion about it amongst surgeons. You know, there was more known by neurologists, but still, even to this day, right? You know, you see someone with CMT and they'll go, "Oh, that's the country music channel," right? And
Right.
you meet your friend and they'll say, "Oh, what's wrong with your tooth?" And unfortunately, so many doctors of different types sort of bluff their way through the visit with CMT. It's just rare. It's a rare disease, and it's hard to know about common diseases, isn't it? Let alone a rare disease.
Yeah.
But get to your final part of your question is I was in San Francisco, and a young woman, probably about 24, came to my office. I was just in practice, and she was just lovely, if I could say that. You know, I just came in. She was very striking. It was like she looked like an Italian painting or something. And I remember her hair was curly and wavy, and I thought, great, this is cool. You know, sports injury, ankle problem, probably just hurt herself skiing up in Tahoe. And she said to me, "Do you know what CMT is?" And I looked at her and she said, "Charcot-Marie tooth." And I think to this day, honestly, I'm paying penance for that lie. I'll never quite get over it because I'm a pretty darn honest guy. But I looked her right in the eye and I said, "Sure." And she said, "Well, that's good because none of my doctors do know about it." And I spied crutches in the corner. And she said, "I'm going to show you something no one's ever seen before. I've never let my parents see my feet. I've never had a boyfriend. I've not been on a date." And I remember when she said, "I've never had a boyfriend," you know, I was married, but a young guy. And I thought, really?
Right.
She took off her shoes and they were these gnarled, twisted feet. You know, I lived up in Marin and they looked like live oaks. If anybody knows, you know, what these twisted jigsaw of a tree, you know. And she said, "Can you help me?" And I said, "Absolutely."
What was your plan? What was going through your head? You didn't have a plan.
What was going through my head is she couldn't live like that. You know, people get feet like that from lots of different reasons. It's not as though this was coming from Mars. You know, people get feet like that from strokes. Not quite as bad, but they do. People get feet like that.
Why don't you describe the CMT foot describe her feet like in terms that people could really visualize and understand if they have those type of feet?
Absolutely. So I think the first thing is, you know, I'm a surgeon. I'm an orthopedic surgeon, and the people who see me in my surgical clinic are people who have CMT and are the 80% of people that have a cavus or high arched foot. 20% of people with CMT don't have that type of foot. Many of those people are completely paralyzed below the knee. You know who they are. You know if you have that. No one wants to be paralyzed below the knee, but in some way it's a blessing because those feet are often just flat on the ground and easily fit into a brace. You know, those feet, if you want to think of it, are a round peg getting into a round hole, right? That's cool. The feet that I'm talking about, the feet that this woman had, young woman, it was a very unbalanced foot. I always give the example, I even have a little video on some of my talks of a carriage, right? And someone's driving a horse carriage through the hills of Vermont, and they've got two reins, right? And one of the reins breaks well, what's going to happen? Now, of course, it's not a horse in a carriage, but the horse starts just going around in circles, right? There's such overpull. Or think of an incredibly strong man having an arm wrestle with someone like me, incredibly weak. So that's what happens in the CMT foot. Certain muscles stay very powerful and certain muscles get very weak. So you get a deformity that occurs.
Mm-hmm.
Just take your hand now, everybody, and just cup it around. Just twist your hand inward. There it is. There's the CMT foot. And the reason that that can happen is the muscles that are twisting it in are strong. Yeah. And the ones that are allowing it to twist in are weak. So that's what she had. And you can't live with that. The number one rule is that no one with a CMT foot that's crooked should live with it. No one with polio with a crooked foot should live with it. No one with a stroke with a crooked foot should live with it, right? No one who's had a fracture with a crooked foot should live with it. But the first commandment of foot and ankle surgery is thou shalt have a foot that's flat on the ground.
Okay.
Right.
And she didn't. And I knew somehow I could help that.
Yeah. And Glenn, just thinking from our listeners' perspectives, right? This is a really important podcast. And what we see all the time is, as we talked about during the intro, is it is very challenging for people to seek out surgery. And I remember during our interview with you, you had made a reference that a lot of people may feel, oh, I can just kind of live with CMT. And really, you know, it takes something to get them to seek surgery. And a lot of people are afraid. They're not very knowledgeable about surgery. They're not really knowledgeable about the outcome and will they get better. And for our listeners, I want you to know, as you'll be able to tell during the podcast, Glenn is a very, again, known around the world, but he is a very caring, emotional individual that, which I always recall, Glenn, you said it the best, is people, you know, if they're questioning surgery, you would tell them, I can help you. I can help you. And I just think it's awesome. So I think our listeners are wondering, gee, should I have surgery? And, you know, do people come and see you? And how do you answer that question for them when they're contemplating surgery and making them feel comfortable to move forward?
Well, if I could just back up a tiny bit, that follows from your first question, is I had a foot problem, as most people in the CMT world know, but I didn't know it until I was 50. I couldn't run like my friends, although I played soccer, you know. I couldn't dance like my friends, although I tried. I certainly couldn't fit into the shoes like I wanted to, but I didn't know why. And, without sounding too corny or something, it gives you a certain sense of isolation growing up. And it gives you a little sense of hopelessness. Now, I was not that bad. You know, I did play soccer and I did dance, but it wasn't until I was 50 years old and president of the American Orthopedic Foot and Ankle Society that I sat down and I said, this is ridiculous. This is not normal. I didn't know it wasn't normal. My mother didn't really know it was normal. The doctors didn't get it. But I knew something was wrong. I hurt and I couldn't do the things I had to, but it was me. We all come to accept who we are, right? Somebody from the CMTA once said, CMT patients accept impairment as the new normal. Right? And that's true for all of us, though. The person, like you said, with your ACL out, right? The person who's got rheumatoid arthritis that doesn't want to get something done. The person who's scared of getting a treatment. It pervades our physical and our mental lives. So, and CMT patients, though, have a double hit, I think, or a triple or quadruple hit. Beside having the normal fear of breaking out of who we are, right? Of stepping beyond the boundary of what we're used to living with, they've always tried. And all they've been met with was hopelessness. The doctor says, try this, you'll be better. Doesn't work. Try that, you're going to be fine. It doesn't work. You know, so CMT patients that I see, of course, it's a selective group, they're patients who've given up hope. And somehow, either through a father, a spouse, a mother, another CMT patient, the CMTA, they've said, all right, let's try one more time. You know, how many times do you fall in and out of love in your life before you say, you know, love is just not for me, right? That's something we can all do.
Right.
You know?
Yeah.
Anyway, it's my job to try to give them back some hope. And it's a responsibility that I gladly take on, but it's a weighty one because I want to be able to look somebody in the eye and say, I can help you. I don't know how much, but I can definitely help you. And you need a flat foot. You don't want pain from a foot that's uneven with calluses on the bottom. You don't want to be tripping over with every step because you're unstable. And ideally, you don't want to be in a brace. And if you're in a brace, you want to be in a smaller brace. And it's a responsibility that's, it's weighty. It's a big responsibility. But I'm glad to be here for these people because
we are all glad that you're here.
Yeah, it's just I get what I'm doing. I don't do it lightly.
So,
Yeah.
Glenn, when we talk about foot surgery, you think of, oh, it's like one procedure, but there are many procedures in a CMT foot surgery. On average, how many do you know what I mean? How many procedures takes place? It's not like, you take a bone out and that's it, or you cut a neuroma out. I mean,
it's very, very unusual surgery and has a level of artistry to it. I'm not patting myself on the shoulder about that. It's just there's a level of artistry to it that's very different than most other surgeries. I was hoping that someone who had previously trained with me would like CMT surgery. Why not, right? How many people really have a big experience with it?
Right.
I asked the guy a few years later, I said, so do you really like this? Should I send you some patients? And he goes, it's actually not for me. I like to plan everything out. I like to have 6 steps to a surgery. How long will each screw be? Exactly should the bones be cut? It's orthopedics. That's what we do. It's carpentry on humans. So I understand that. And I said, well, what is it about CMT? He said, every step is an audible, like in football, Get to the line of scrimmage and you don't know what you're going to do really until the other team lines up. So Elizabeth, the answer to your question is the surgeries take somewhere between 3 and 5 hours. There are probably 14 or 15 different procedures that are done. And every single one of them is dependent on the prior. It's wonderful for my mind. I couldn't think of anything I'd rather do. Really? But I was surprised to understand that it's just really not right for most surgeons' minds. What we need to do in a nutshell is make the foot flat, right? If anyone listening to this has calluses on the bottom of the foot that are, bad and painful, you should have an operation, even if you're in a brace, because then the foot will fit into a brace better. 2 is what I said earlier. You have to not be falling over. Some patients in my office, when they're out of a brace, they have to hold onto the wall, right? Mm-hmm. Many people are like that.
Right.
And 3, our goal is to transfer muscles, which is such a miracle. And you transfer these muscles around so that the one that's over pulling now is pulling in the right direction. And that's just, a miracle. I mean, I think you and I talked about, how I used to do a lot of magic and I still do.
Exactly. Really, really good with your hands, doing a lot of magic. Yeah, definitely.
But I mean, I was making money working in nightclubs when I was working through high school. I performed at the Rose and Crown on Martha's on Nantucket for a couple of summers. And it's a little peculiar maybe, but I would just get such a kick out of watching me do a magic trick in the mirror. And I would just do it 6. I was practicing, granted, but if you're holding up a dice and all of a sudden it turns into a flower. It was just so cool. And it's the same way I feel with these feet. You start with a round piece and you end up with a square piece, or you know what I'm saying.
Yeah.
And then they come to the office and they're 2 weeks later, and everybody I've operated on who's listening knows this. I'll carefully hold the foot and I'll say, okay, just try to move it. And it moves the way it didn't before. And that red card had just right before my eyes turned into a flower,
Yeah.
Right.
That is
Actually,
great.
I remember like someone can lift their foot for the first time, right? After a certain period of time when that's allowed. They can lift their foot after
Right.
a long time.
Yeah. And one thing I was thinking, Glenn, is there someone with CMT, is there a process in terms of, should someone seek braces over surgery? Or is it just dependent upon the individual and the severity of the CMT?
Look, there are some people with CMT that's catastrophic, right? Fortunately, it's not many. There are people in wheelchairs. There are people who can't move their upper extremities. There are people who can't breathe well. There are people who live in chronic pain. It can be just a horrific,
Devastating. Yeah.
But for the vast majority of the CMT patients that I'm talking about, right? These unbalanced, painful feet, they can live with it. Sure, they can live with it. People can live in braces. People live with no hands. People live homeless. People live with chronic disease. But orthopedics and what we're talking about is about quality of life. And it's a question of what quality of life somebody has. Many of you have seen this Instagram thing that I do. I'm kind of I still remain my generation. I'm still embarrassed about it. You have to understand, when I went into business in orthopedics, if I had given any kind of advertisement, I would have been thrown out of medical societies, right? It would never have been accepted to advertise.
Mm-hmm.
And I didn't even know what CMT was, if Instagram was, until 5 years ago. And I said to a 16-year-old, she was so happy, she was back for her other foot, and she was from Kansas. I said, how do I reach out to 16-year-olds? What do I do? How do I let people know I'm here? So many people come to see me and they go, we didn't know you were there. Right. And she said, well, try Instagram. And I guess, Elizabeth, that was the second lie of my life. And I said, oh yeah, Instagram, of course.
Right. Oh yeah, I know how to use Instagram.
CMT, sure. I know what that is.
Mm-hmm.
And I went out, I said to the resident, I said, what's Instagram? But it's quick, you set it right up. It took a couple of minutes. And then that weekend I went to get my hair cut. And I said, how do you use Instagram? He goes, well, you want to post a movie? That was the beginning. And
that's great.
You have quite a few followers. What is your Instagram name if somebody wants to look at you or listen to you on Instagram?
Oh, it's Charcot Marie Tooth Surgery.
Okay.
And or else Glenn Pfeffer. And when I first got my first 10 followers, I thought, oh my God, this is such a success. I haven't looked lately, but I think it's up to like 2,600. Although I noticed that I'm not getting as many comments people from Russia lately.
Oh, okay.
I wonder why.
Yeah, I wonder why as well.
But you do see people from all over the world.
All over the world.
All of them come in.
It's yes, but it's a very privileged person who can come from out of the country. A surgery at Cedars-Sinai was just voted the third best orthopedic hospital in the country, the orthopedic center. And that's a big deal. And people come to us just because we're really good. But American medicine is so expensive, right?
Mm-hmm.
Right.
There are probably 20 people involved with the CMT surgery, from pre-op to post-op to nurses to the equipment people that are bringing it in, to x-ray techs. It costs a fortune. And in this country, there is an impediment sometimes, which breaks my heart, when someone has an insurance that doesn't allow them to be operated on out of state. Mm-hmm. Everyone thinks, yeah, I've got great insurance. A young fellow was talking to me. His dad worked for one of the car companies. He goes, we have great insurance through the union and the car company. It wouldn't let him come. So you had to work on that and change insurance. You guys have a great program now, as you know, where they're through a generous donor. I don't know if he wants to be anonymous or not, but someone who has insurance that lets them come, they can get up to a $5,000 grant just to help with airplane or even a babysitter at home. So that's a blessing. But the people out of the country, I often talk to them, on video chats, but I would say 98% of them can't come. And it's always the same kind of plaintive issues, please, my 8-year-old can't walk. Here's a video of her feet, and I can help her.
Right.
And there's nothing I can do. I often think, just parenthetically, that one of these days I'm going to take off 6 months and just travel around the world and put out on Instagram saying, if you can arrange for me to come to your country, I'll operate on you. And it might be a last, chapter for a career one day.
Are there any CMT feet that you cannot operate on? Have you had that where it was just, I don't know, so bad that, because some people say, I am thinking about amputation, for example.
Yeah, no, but yes. I mean, there may have been somebody, maybe somebody's listening and I've forgotten about that person, but basically, no, depending on the expectation. Can I get everyone out of a brace walking comfortably? Impossible, right? Do some people have surgery and start to get worse because of their disease? Absolutely. But no, I can take anyone whose foot's not flat and is painful and make them flat. There's a tremendous experience in this country from very big reconstructive surgeries with polio patients. Mm-hmm. That's the type of problem they had. There's one young fellow, I think we had talked about him, and he came to see me from the East Coast. He'd had surgery. Now, that could be a very difficult problem. Mm-hmm. The real issue for me is not whether or not I can operate on them at all, but whether or not I can get someone as good as I'd like. Mm-hmm. And the people who've had surgery already are really difficult, because I'm not only dealing with CMT, but I'm dealing with surgery that's not been done right. So that's true. And it's true for anything you do in life, that's mechanical. But one fellow 4 months ago, almost to the day, he came to see me. We had corresponded. He had had surgery. He had that crooked foot that was painful. He couldn't walk. He was falling over. And he said he wanted an amputation. And I said, no, I can help you. And he came to see me. I hadn't met him in person until the day before surgery. And if you talk about dashed hopes, who am I to give somebody hope that they could have surgery based on a video chat and then tell them I can't do it? It's never happened to me, by the way. Never happened.
Good.
But he came and I said, I can help you. It's a little dicey because you have incisions where I don't want them, and you have bone cuts that have to be corrected. He said, okay. And he texted me that night and he said, Dr. Pfeffer, I've really thought about it. And if you don't think you can deliver, or you don't think you can help me, it's okay. I've come to peace a long time ago that I'm going to have this leg amputated. So just let's amputate it tomorrow if that's what you want to do. So, a little pressure.
Right.
Yeah.
Anyway, fast forward, we didn't amputate it. And just, I'm a corny guy. You got to forgive me. It's not on video, but it's so often post-operatively, 2 weeks after surgery, that there are two people that are teary-eyed in the room, my patient and me, and or maybe mom and me. But just thinking of him, he just texted me maybe a week ago, 2 weeks ago, and he said he had problems with his wound. He said, the wound's healed up finally, and I just, for the first time, basically in my life, just walked through the woods, snowy, with my kids, with no pain and not toppling over.
Isn't that amazing? What an amazing story.
There are so many stories like that.
He's about the worst, that I had. Not everybody's better. There's certainly been failures, and those are the ones that weigh the heaviest. Most of the failures have been because of some progression of disease. I always wonder if I could have done more. There'd been one person that had a bad infection, and I'm not sure if that could have been avoided. And then there have been a few people I've overcorrected, and that was so surprising. But it has to do with new techniques we're using that have benefited so many. But but that's always, it's
Yeah. So Glenn, when you reference new techniques, what are some of those new techniques or surgical methods being employed today?
Yeah, it's a great question. We've made so much advance since I got interested in this. We really took off since we gave there was CMTA gave a patient outlook or patient outreach meeting here in California, and I had the gumption then to come up to the CMTA and say, "Listen, will you give me a grant to do some research? I have some ideas." And I'm not sure the CMTA actually had ever worked with a surgeon before. It wasn't exactly in their mission. I don't know, Elizabeth, you can let me know, but for some reason it happened. And boy, that started a snowball effect. The first paper we did was looking at the complex three-dimensionality of these feet, right? These are not simple feet. They're very twisted, right? And we looked at that using 3D prints. And I wasn't much of a researcher before that, but we won an international prize of one of the papers most likely to affect orthopedics over the next 5 years. And we've moved along with that, looking at how to balance tendon transfers in the lab. The whole issue is, how do you balance these feet out well enough to keep them out of a brace, ideally, or a smaller brace?
Mm-hmm.
What kind of bone cuts do you make to bring the feet flat? In general, in the country, surgeons are very frustrated with CMT because they don't come out of the operating room with a flat foot. And what does the patient know? So they're told, look, it's better, and it is, but it's not good enough. So just recently, we finished 3 research papers, which are just remarkable. And I say that objectively because how does Boeing, or how does NASA, right, the company, the space agency, change the shape of an airplane wing, right? How do they describe an airplane wing? How do I describe your face? Describe my face. We go, oh, the eyes, the nose, we'll make this a little wider. But what these people are doing is they're taking millions and millions of tiny points on the shape and putting it into a computer and having the computers talk to each other and analyze it. You see, one day, all of orthopedics is going to be like this, especially with CMT. Siri, Alexa, this is a pretty complex deformity in the foot, isn't it? Yes, Dr. Pfeffer, it is. Would you like a suggestion? Yes, Siri. How can we best correct this CMT foot? Well, there are three options. Then what's going to happen is sterile jigs, just like we use a jig to cut, I don't know what, some lumber, are going to be printed out in the operating room. We're going to be able to hold them up to the foot and take a saw and cut just the way Siri tells us. But we're a long way off because we can't even describe the CMT foot yet, right? So the bottom line in one sentence is, I found a company in Finland, and we started working with them. The way that Boeing works with an airplane shape, we worked with them in terms of the CMT foot. And we actually showed for the first time, I think, in anything in orthopedics, something that everyone knew but never proved, that abnormal pull on a muscle, right? CMT throughout a limb changes the shape of the bone. So that's why a regular approach to the CMT foot doesn't work. That's why surgeons are so frustrated getting that heel out of position, because what we're used to is not what we're dealing with. We're not dealing with just a regular bone. We're dealing with a misshapen bone that we don't understand. So I don't mean to go on about it, but it's absolutely so cool. It's just—
That's great.
Yeah.
And how many foot surgeries have you performed in your lifetime?
Oh, I was trying to add it up. Probably about 700.
700.
Right. And to put that in perspective, Max Mikowski, my junior partner, just gave a paper that we worked on in Phoenix. I drove out to Phoenix and I went on to the Grand Canyon driving around. It was great. But I was there in Phoenix and he gave this paper last week. And there were orthopedic surgeons anywhere. And there was a woman orthopedic surgeon I didn't know sitting behind me. But Max gave the paper and he said, well, we're going to talk about the 95 CMT feet that we've operated on this year. And this is what I heard. I heard her behind me going, my God. Because that's just a number that's probably 10 times more than anyone else has done. And it's just the way it is. Everyone has to remember, all of us have to remember, and surgeons have to remember, it's a rare disease.
Mhm.
And that means rare diseases are not seen much, right? And it's an even rarer surgical disease. So odds are when anyone listening goes into a surgeon, it's not something they've seen much.
Mm.
Some of them will be skittish. Some of them will say the worst possible thing, which is there's nothing to do for you. And others will try to tackle the problem and just not be up to it.
So I know in Europe there used to be a lot of CMT fusions, like foot fusions, right? Foot and ankle fusions, right? And is that still the case today? And did you ever do ankle fusions? And what changed that?
Yeah. So we just have to get the terms simply down.
Yeah.
There's the foot and then there's the ankle.
Okay.
Right? So the ankle is what goes up and down, and the foot's the rest of the stuff, what's causing the heel to be in. I'd make a general rule that a CMT patient should never have an ankle fusion unless they've let it go so long that the ankle is just destroyed. But please don't let it go that long. If I can get a message out, it's don't live with a crooked foot and get this taken care of as soon as possible, and at least get a consultation with somebody who knows. Don't give up hope if there is still hope there.
Right.
And you just don't know until you've gotten the right opinion. But Elizabeth, never fuse an ankle. Once the ankle, the part that goes up and down, is fused, all these terrific CMT braces are nullified. You can't get the benefit from them anymore. There are people who are completely paralyzed that walk in braces and you'd hardly know it, right? We talked about them before. All the other problems in the feet, you'd like to do as few fusions as possible, right? Because a fusion on one joint places stress on another joint. But there's nothing wrong with a fusion of some of the joints in the foot. Nothing. As long as it's done well, and as long as the person doing the fusion understands that the bone they're fusing is not a normally shaped bone. See, normally with a fusion, maybe we do one thing, it's fused, you put a screw across it, go have lunch, go on to the next case. These joints can't be treated like that. Because we just showed in this recent study. So a fusion that's done well, absolutely fine. Some of my happiest patients have limited fusions. But as a general rule, avoid fusions if possible, especially in younger people, and never do an ankle fusion. And if your doctor is telling you, your surgeon, that you need a fusion, I might back off and just get another opinion.
So you talked about the younger patient. What's the youngest you would do surgery on? Like, isn't there a point, I know with hips and other parts of your body, that you have to wait till things develop, or hip plates fuse or whatever, there's a certain time that you're still growing, and maybe you'd stunt growth if you do it beforehand. So what's the youngest you would consider doing a surgery, or is age even a consideration?
Is it a factor, right?
Yeah, well, for me, I won't really operate on someone younger than about 7 or 8. That's about my threshold. But there's someone who works here over at Children's Hospital who's world renowned and will operate on 2, 3-year-olds if it's needed. Often with younger patients, you can do physical therapy, you can do stretching exercises and see how they develop. But I think the message I would give is the day that a CMT patient wakes up, and whether they're 5-year-old or 6 years old, and the parents look at their foot and they say, I don't want my child to be that way the rest of their life, that's the day to start seriously considering surgery. Especially based on our recent research, the more normal muscle pull that can be put on a foot, right? Just the reins can be equal, the less deformity that will occur. Let alone the emotional and social stigmata. In my own tiny way, my foot doesn't work. My left foot doesn't move. I was born with a partial fusion. And I could just only think back to what I went through, which was just a fraction of what a CMT patient goes through. just with the, the isolation I had and not quite being able to dance quite as well. And you don't want anyone to go through that.
Right.
I spoke to an orthopedic surgeon recently and I said, am I being too aggressive? He said, I have a 7-year-old and they're doing okay in braces, but their feet are crooked and they hurt some and the family's reluctant, but the child wants surgery. The child says, Mommy, I don't want to be in braces. I said, maybe I should just let it go. And I was surprised because I really respect this surgeon. And he said, no one wants to live in braces if they don't have to.
That's true.
It is
Yeah.
true.
Yeah.
And so
You know,
I told them, we'll see what they do. We'll
Yeah.
see what they do.
One thing I wanted to talk about is, again, someone who is potentially entertaining surgery, and it can be nerve-wracking, right? They're very nervous. I think they're trying to get a sense of trust and what is the relationship they have with their doctor. And, I just wanted to know from your perspective is how do you approach that kind of doctor-patient interaction and relationship, right? And you're very, I think, unique. I just love your approach and style, and you're very warming. And I do think that goes a long way in terms of someone making a decision of the doctor that they're going to trust to operate on them. So how do you interact with your patients?
Yeah. Well, first of all, fix what you can in your life. There's enough that you're not going to be able to fix, right? There's just certain things you can't. So for everyone, in anything, fix what you can.
Mm-hmm.
2, CMT patients ask me, will it progress? What's the point, Dad says, if it's just going to get worse? It may get worse. That can be the nature of this disease. But if you're at a C- now, what's going to happen when you get worse? Let's at least get you up, and I can pretty much promise, if I can, a B+. And then you may end up at a C-, but at least you've tried. At least you've done all you can for yourself. Next to a patient and their family, I do not live well with failure. When we're in the operating room, I said to the resident yesterday, we just did a CMT case, a gal from Boston yesterday. She was so reluctant to do the surgery. She was so scared. But I said to her, there's one person in the room who worries more than you do, and that's me.
Yeah.
She goes, I like that about you, Dr. Pfeffer. I think that may be true. Yeah. So often by seeing me being such a nervous wreck about it, or a worrier, so obsessive, I think my patients that are so worried, it gives them some freedom because they know they're relief. They know I understand. The CMT patients get my phone number. And I tell these patients, whether they're 70, and I've operated on 75-year-olds, or whether they're 6, I've adopted them. I really feel that way with all my heart. And I don't live well with failure, and I don't want to bring that on myself. It's a very good protective mechanism for my CMT patients. The last thing I want is to live with someone who's doing poorly. And I'm an employee of the hospital. I don't get any extra money. I don't get, money for this blog. I don't get money for the Instagram stuff. They sign my contract every 5 years and no one seems to be unhappy with me.
Yeah.
It's a wonderful way to be a doctor,
Yeah. And you have great stories, which I, learned during our pre-interview, is you stay close with your patients after surgery. You've told some stories of where you pick the phone up and call that person and check in on them, whether that's a month later, it could be 2 years later. And, that's just really special. I mean, really special.
Well, it's what keeps me going. I'm not far from retirement age. Surgeons retire at different ages. I have no plan on it now, though, but really for one reason, only one. It's the CMT patients. It's given me more in my career exponentially than I could have hoped for. It's given a tremendous spirituality to my life. I get a text with a little video, about Katie, and I operated on her, and she was so scared, and she didn't want to do it, but she couldn't hold on to the wall without walking, and the family's scared. And you get a text video that shows her playing baseball with her dad. in a field, not toppling over, throwing a baseball. And then, oh God, the only caption underneath is from the father, it's, "Gee, Doc, thanks for giving me my daughter back again."
Right.
Yeah. So Glenn, what happened to that? That's a beautiful moment. I don't want to cut that off. That's a beautiful moment. And I think you get these texts quite often, as I know you, and you're very warm and comforting and also very attentive. What happened to that first woman, the 24-year-old that your first CMT patient? How'd that go?
Yeah, well, if we just have the time, I'll tell you that quickly, and then I could join the story. It went great. I studied for about 3 months. I spoke to everybody literally I knew in the world. I was even then well connected in the foot world. There wasn't too much to offer. The goal was to balance the tendons and make the foot flat. Maybe I could have gotten even better today, knowing what we know, 30 years later. But she was good enough to come back and have the other foot, and the feet that she'd never shown anybody, she ultimately showed a boyfriend. And then I got an email from her. It wasn't text time, but I got an email, and she said, "I just want to thank you again so much. I'm married now and have some children."
That's awesome.
And she says, "My kids don't have CMT." But it's a lot of that's what surgeons do. You wonder when anyone goes through training, an airline pilot, a surgeon, you go through your training not for the easy moments, but for the hard ones, to get through those difficult times, or to take the challenge of the hard case. You just remind me of another story, if I could. It followed shortly after her, and somehow somebody up in Eureka had heard about the success of this. Even then, there was, I suppose, some CMT community or communications, online. And I saw a young woman, same age, a little younger, came to the office with her mother. She was a minor, actually. She was 17. She was a little younger. And we decided to operate on her foot. Very difficult problem, crooked, unbalanced, didn't want to wear braces. So many patients come, and they're at a critical juncture of their life, and they're 15 or 16. They know they're going to college, 17, and they don't want to wear braces. Anyway, that was her condition, and we got her scheduled for surgery. She went to surgery. I was about to go in the operating room, but nervous. This was many years ago. I didn't have 700 cases under my belt. And the mom takes my hand, which I thought was lovely, and she looks me in the eye, and I could use that, a little extra strength.
Sure.
And she said, "Do not operate on my daughter." And I said, I smiled. I just smiled. Yeah, okay. And she wouldn't let me go. And she took my hand, and I knew that she was very, very religious. And she said, "I want you to know the church is praying for us today and my daughter, and you mustn't operate on her." And I just looked, and I said, "What do you mean?" And she said, "God will transform her foot in front of you on the operating table." She says, "As happened with Abraham and Isaac." And I said, "I know that story." I said, "I'm Jewish, but not very religious. And I'm not sure this transformation." I said, "Really?" And she looked at me with the stare of incredulity that it would not happen. There was no issue this was going to happen. "You will take a breath. We will see the sun. Her foot will be transformed." I didn't know what to say. And I just thought for a minute, and in a way, what happened over the next 20 seconds discussion with her has truly given me great strength in my life, and has really, you asked about the CMT patients, has bound me more with the CMT people, my CMT family, than any other patient. She looked me in the eye. I looked her back. Oh God, it's hard to even say. And I said, "Well, what if I'm God's instrument? What if I'm the one who's meant to transform her foot?"
Right.
And she stared me in the eye, and she said, "Okay, wait 5 minutes. If it doesn't happen, do the surgery."
Oh my goodness. Oh.
I operated on her. I operated on her
Crazy.
brother. I operated on her brother about 6 months later, and I know they're still doing great.
Oh, that's
Oh,
awesome.
that is awesome.
But I
Awesome.
guess in some way that from that moment on, it has been my mission.
Yeah, Glenn, it's coming to a close for the podcast, and I wish we could continue. And just so our listeners know, I think this is maybe our 12th or 13th recording, and I have been teary-eyed the entire time. So you're just a wonderful person. I think it's fantastic in terms of your dedication to the CMT community. And you said something that I think is so great when you talked about hope. And you made it this reference. You said, hope is the last thing to die. And you said that during the pre-interview. And I wrote that down, and I kind of carry that with me today in terms of your comment there. And I think that's so true, right? And that's where you can play a role. And you've dedicated your life to that. And people are fortunate to have gotten to know you. And if they don't know you yet, they should reach out to you if they're considering surgery. And you're just a great individual.
Can't thank you enough, Glenn, for all your work with everyone. Really can't thank you enough.
Well, I can't thank you enough for having me, and it's because of the CMTA and people like you that the hope remains alive in CMT.